So this is a radius, and important to cite it, and a few clues that you can always get are that the head is proximal, okay, because obviously it articulates with the capitulum of the humerus. And this makes it the distal end. You can usually find the radial styloid, which is this pointy thing here. You can always see that, and that's on the lateral aspect. Plus you always have this flat volar surface, whereas on the back it's nice and curved. And if you find this little area here, the radial tubercle, that articulates with the ulna, so then you always know this is the left radius, and this is its volar surface, and the other side is its dorsal surface. So we know this is the head, has a neck, body, and base. And the important aspects are the radial tubercle, which has the attachments to the biceps brachii, pronator tubercle for the pronator teres, and the radial styloid at the distal end, which has an attachment here for the brachioradialis. This sharp ridge is easy to always see because that forms the interosseous membrane. Just to show you how it does all fit together, usually like that. So it sits together and that forms that interosseous membrane in between. A few muscles that we should talk about, and we've touched on them. Biceps brachii at the radial tuberosity, and the shaft laterally of the supinator, pronator teres, and the anterior aspect is your FDS, and then your FPL, which has a broad attachment, and then the PQ, pronator quadratus, that forms the distal edge, and that actually then articulates, has its origin insertion, and articulates on the distal edge of the ulna as well. The distal end, important to look at here, we said that was the radial styloid with the brachioradialis process. That makes this the ulnar notch, or the sigmoid notch for the ulna, with Lister's tubercle sitting as its ridge, and that separates the extensor compartments between your EPL and your EDC. And that's usually classically where you get ruptures, attrition problems. Here you also have the DRUJ, distal radial ulnar joint, and there's a scaphoid fossa and a lunate fossa as well. When we talk about taking flaps, obviously the radial forearm flap is key. That's based on the radial artery. Distal third usually is a free flap because it's where the radial artery comes out through brachioradialis pronator teres and then runs distally between your brachioradialis and your FCR, and then gives off your majority of perforates in that distal third or that proximal third. But the bone that you can take is usually a third of this, and you can take it up to the level of where pronator teres is, usually leaving a little cuff of FPL over it. Sometimes we also recently have taken PQ flaps which are innervated and work well, and you can usually make your cut perpendicular, turn it 90 degrees, make your second cut and take off that segment. You need to plate it. There is a high risk of fractures afterwards.